Thanks. Well, thank you for having me. I'm going to talk a little bit differently from most. So I am a practicing pathologist. I run a commercial laboratory. And so what I'm going to give you is more the practical aspects of how we're going to apply some of these technologies into the laboratory. And so I'm going to start by sort of what's the job that a pathologist does in my mind. We've got about 1,500 clients throughout the United States. We're worldwide now, so we're accumulating more around the world. And I sort of look at pathology from really three main vantage points. When we establish a diagnosis, what we're really asking is, what does that mean for the patient? When I tell you that you have something, what's the impact of that? What does it mean for your family? That's something that we largely don't deal with today as pathologists, but now in the genomic world, that's becoming increasingly important. And more importantly, where everybody's focused is, now that I told you what you have, what can I do to change it? And more importantly, if I can find a target, can I also tell you about the resistance mechanisms to that target if you apply the therapies? And when we talk about this as precision medicine, and it's great to talk on the genome level about precision medicine, but there's a lot more to it from a pathologist's viewpoint. It's what the tumor looks like grossly, how it presented, what it looks like under the microscope, and then now it's not just about the genome, but it's also about the proteome, et cetera. So what I have to deal with is the practical realities, because in essence, we don't get paid unless the test has demonstrated clinical utility. So it's great to run a bunch of tests, but if somebody can't actually act on the result, and if that isn't demonstrated for payers, then their new position is, that's great, we just won't pay you. And the ongoing fight, for those of you that don't know, is the whole molecular underpinnings is sort of under siege right now because the reimbursements have been under attack. So things like these common genes that we're looking at now are really being reimbursed at the $100 level, more or less, either just over or just under, which is very difficult to sustain in a clinical laboratory. So what we're focused on and what we talk to payers about is how we do testing that has demonstrable clinical utility, meaning that we can tell which patient will respond with a drug and which patients will not have toxic effects. And being able to answer either one of those two questions is enough to shift the balance in oncologists and other clinicians' minds upon which therapies to provide. So, best example of this, of course, would be a drug like vemurafenib given to patients with V600E positive melanomas. And the beauty of this is not just that the drug works, is that it works in an incredibly short time interval. So literally within a few days, you can watch lesions disappear. Now, we know you don't get that sustained result over time, but this is the sort of thing that payers want to see, that we identify something through a test, a drug can be given that wouldn't be given otherwise, and there's a dramatic outcome. The impact to us as pathologists then becomes that a bad test is just as bad as a bad drug. So when we talk about testing, now we're talking about not just can we do it, but can we do it on the sample that we have? Can we do it reproducibly, and can people actually act on that result? And herein lies the problems, because a lot of the testing that we talk about when we say, well, we've got this mutation or that mutation, is will it be identified the same way in every laboratory around the world? Because if it isn't, then nobody actually knows what to do with the result. You get a result, is it a false positive or is it a false negative, and will you in fact be giving the wrong therapies? So if we take something like lung cancer, when I went through my residency, lung cancer, relatively simple, squamous adeno, small cell, large cell, that's it. Nowadays, we don't really even talk about those things anymore. We're talking about what are the specific drivers of that lung cancer. And today, we're focusing on adenocarcinomas because we have EGFR-related therapies and ALK-related therapies. But the squamous cell carcinomas are driven by specific mutations as well, and those therapies are coming. Now, why does everybody care about this? Well, everybody cares for two important reasons. One, being able to understand the target allows drugs to be created that are much more likely to succeed, and the success rate of oncology drugs is the worst of all the biopharm categories. So being able to understand a target and having a therapy directed at that target makes it much more successful. And having a companion diagnostic to identify that target has been demonstrated to reduce the time for that drug to make it to the public and also to reduce costs of the trials overall. So a great example of this, well, not a great example of it, but an example of a targeted therapy would be the small molecule tyrosine kinase inhibitors. Here's the IPASS trial with Iressa, basically demonstrating that patients that have the mutation that get the drug do significantly better than those that got the chemotherapy arm, and those patients who didn't have the mutation that get the targeted therapy actually do worse. And it's not just that a mutation is a mutation is a mutation. You can look at differential outcomes by the specific mutation that's present. But it's slightly more complicated than that because not even all mutations are beneficial. Some mutations are beneficial, but some mutations actually confer resistance. And there's a whole host of mutations that we're not quite sure what it does yet. So we've broken them down into broad categories, those that involve deletions in exon 19 or substitutions on exon 21 generally confer benefit. Those that have insertions or deletions on exon 20 are generally bad and confer resistance. And why do we think that is? Well, the molecule, the drug itself, is a reversible ATPase inhibitor, and consequently, it's about binding affinity of the drug relative to ATP. So some of the mutations change that ratio into a favorable ratio, and sometimes it goes into an unfavorable. And you have to know the specific mutation to be able to identify which effect you're going to get. But as a pathologist, when we're presented with non-small cell lung cancer, these are the sorts of things that we wind up dealing with today. And at the gene level, while we do deal with things like EGFR and ALK and now ROS1 and RET and potentially others as well, at the protein level, we're also interested in EGFR, MET overexpression. Histology still plays a role. The other thing that we have to deal with is what's going to be our general approach. So if the whole world were just single gene assays and I only had to worry about one specific mutation, that would be easy. But the world's getting more complicated. We've got more areas of the genome that have to be dissected. And so you have to decide how are you going to go about that process. Are we going to just run multiple single gene assays? Are we going to develop assays like Snapshot and look at multiple hotspots at the same time? Or are we going to move on to next-gen sequencing? And if we do that, are we going to do targeted resequencing? Are we going to do all exomes? Are we going to do whole genomes? And the issues as a lab somewhat come down to reimbursement levels because there's cost associated with doing each of these things, but there's also complexity and confusion that arise the more that you do. Because remember, we have to come up with things that are going to be actionable in the laboratory. So what are the stresses on us? Well, if we take something like lung cancer, the sample size keep on getting smaller and smaller and smaller. Frequently, they're just FNAs, but the targets that people are interested in keep on expanding out and getting larger and larger. So at some point, you either trade off and say, I can only test for these certain targets with a limited amount of tissue, or you apply technology to get more out of the smaller samples. And I think that's the spot that we're really at right now. We have one other really complicating issue for pathology, and that is that most of our samples are formalin-fixed paraffin-embedded tissue. So it's great to talk about frozen tissue and what are all these great things that we could do, but we have practical realities. These are the samples that we have. And because of that, they raise some concerns, because as you know, the formalin-fixed paraffin-embedded tissues are not the best overall samples. So we have to worry about how amplifiable is the DNA, how many mutant copies are present in our sample, what's the background of normal cells that's present. And not only that, what inhibitory substances are present in the sample? Because they're not just pure tumor cells. There's other things that are intermixed with the sample. And so this is just a little schematic that highlights some of those issues. Most of the mutations that we deal with are heterozygous mutations. So if I have a tumor cell, I have one normal copy of the gene, one mutated copy of the gene. If I have a pure tumor sample, that's relatively easy to find. I've got a 50% mutated allele burden. But I frequently have it admixed with normal cells. And given that, I need an assay that has sufficient sensitivity to do that. Some mutations that I get, like EGFR, are frequently amplified. So it makes the process a little bit easier. I don't have to worry so much about background cells to be able to do that. but it just means you have to understand the biology of what it is that you're looking for to design the assay properly. So a great example of this came out with the approval of the V600E BRAF test on the COBAS instrument for the drug vemurafenib. It was the companion diagnostic that was approved with the drug. And as part of the study for that, it's an allele-specific PCR closed box system, but as part of that study design, the performance of that box was compared against Sanger sequencing. And the surprise was that Sanger sequencing missed about 20% of the positive cases. And it did so in some cases because it was invalid, but most of the cases just because the mutated allele burden was too dilute. There were too many normal cells that were present because melanoma cells are big, they're frequently infiltrated by lymphocytes which are small, they have normal BRAF content, and consequently the mutated allele burden got missed. And when the same samples underwent 454 sequencing, in this case you just go a little bit deeper, you can see that the mutations were actually present. So that was just a limitation of Sanger sequencing. So our push as a clinical lab is to say, how are we going to do more and more with less and less? And NextGen has a lot of appeals to it because we can multiplex these multiple genes, hopefully at a lower cost over time. We can get that increased depth of read to get back the sensitivity level that we were missing with Sanger sequencing. We can get broader coverage around areas if that becomes important. And of course, it allows the discovery. Now, that's not what I'm talking about from a clinical sense, but we've already heard from all the other talks the importance of NextGen in the area of discovery. So it's just a quick sample basically showing that NextGen sequencing, in this case, this is with the TruSight panel, provides the full breadth of Sanger sequencing, but allows the sensitivity of PCR. So I don't have to worry about my real-world samples being diluted. I can make up for that by just going at greater depth and being able to still identify the specific mutation. In addition to that, if I cared, I could go beyond the hotspot coverage and go to fuller, more complete exome coverage of the genes in question, so that I could potentially identify important important mutations that otherwise might have been missed. Now, when we talk to regulators about this, our main point, and I can't stress this enough in the room, is that NextGen sequencing is more than just getting the sequence. It's everything around it. It's the sample prep, and more importantly, the bioinformatics at the back end. So everybody is used to seeing these graphs of the cost of sequencing is dramatically decreasing over time. I can tell you that the payers and the regulators look at that and they go, oh, NextGen's free. This is great. We're going to be able to get everything and there's going to be no cost to anybody. Or I could run a $200 test and get the answer to everything. And so it's very important for us and others to say, yes, the cost of sequencing is dropping, but not the cost of analysis, not the cost of prep. The more we do, the more complex it gets, both in upfront prep and in back-end analysis. And this is just a little schematic that we show them saying, yes, when we started, it was all about the cost of sequencing, but now that we've dropped the cost of sequencing, it's really the cost of the sample prep and the bioinformatics on the back end that's really going to generate the overall dollar cost. Now, one of the things that I have to stress as a laboratory director is garbage in, garbage out. So it's great to show all of these complex things, but you have to start with a good sample up front, and you have to understand, how do you pick where you pick? And this is really a big deal, by the way. This is a big deal for us in really simple everyday things. So for example, I'm predominantly started my career as a breast pathologist. The two most important things that we do in breast cancer today is give an ER status and a HER2 status, right? Can't even imagine a breast cancer patient without knowing what's your ER status and your HER2 status. Any positive cell really is considered positive for most clinicians. So if an ER positive area of a tumor is most likely in the best differentiated area of the tumor, and if a HER2 positive cell is most likely going to be in the most poorly differentiated area of tumor, how often do you think breast cancer patients get tested on two different blocks? The answer is never. A block gets selected, and because that block gets selected, I guarantee you that there are patients that are called ER negative that are actually positive, or patients that are called HER2 negative that are actually positive. And there's actually clinical trial results that demonstrate that. You can take a second block and watch 5 to 10% of the time. You'll get the opposite answer. Well, this comes to bear even greater when we talk about these mutational burdens that we don't quite understand yet. And I'm using this paper as an example. I'm not making any commentary on whether it was a good paper or a bad paper or anything else about it. But this was a paper that basically sampled several cancers, a small number of cancers in several different regions of tumors and then in several different metastatic lesions, right, from 4 different patients. And what they found was significant heterogeneity. So basically in gray is where mutations were identified, and the blue is where mutations weren't. And you can see there's a series of mutations that are ubiquitous. They were both in all regions of the tumor as well as in the metastatic areas. There were mutations that were only in the primaries. There were mutations that were only in the metastasis, and then there were isolated mutations all over the place. What that meant in the end was that only about 30% of the mutations were ubiquitous, meaning it would have made no difference where you sampled, you would have got the mutation. But that meant that 2/3 of the time, if you sampled in a different area, you wouldn't have gotten those mutations. Or the mutation that you discovered would be specific to the block that you selected for analysis. So that's got some problems associated with it with me as a laboratory person, because I have to be able to explain to somebody what that negative result meant and what that positive result meant. And if I told them, well, I don't really know what it means, it's probably only related to the block that you gave me, and if you picked a different block, I would have told you totally different things, they'd look at me like I was nuts. Then why are we doing this to begin with? The other thing that we have to contend with is extrapolating what we know from one organ to another organ. So is a mutation a mutation? So for example, if we look at KRAS mutation ability to predict lack of response to anti-EGFR antibodies like cetuximab or panitumumab, in colon cancer, that works. But in the forget which trial it was, but in the FLEX and the BMS trial for lung cancer, it actually didn't work. So if you had a KRAS mutation but you got the anti-EGFR drugs, there was still an absolute benefit. So that's problematic. We see the same thing in BRAF. For V600E mutation in melanoma, vemurafenib's a home run. But in colon cancer with V600E mutations, it doesn't appear to have efficacy. So a mutation isn't just a mutation. We have to know the context of the mutation as well. So this is a paper that just came out a week or so ago, maybe about 2 weeks now, by Dr. Vogelstein. It was the subject of his platform presentation last year at AACR. But in essence, what it talked about was the overall science of somatic mutations. And in essence, what this shows is the distributions of mutations based on organ. And we've already heard some of this in the talk. If you have things, for example, like mismatch repair protein defects, then as you would expect, the number of mutations in those sorts of colon tumors is through the roof and the highest that you'll see. I mean, literally 1,000+ mutations. Those that are driven by known carcinogens, cigarette smoke, UV radiation, so lung cancers versus melanomas, very high mutation burdens. But if you look at others, especially those that have very short longevity, like pediatric tumors and others, actually very low mutation burdens. So there's issues not just how many mutations you have, it's what mutations, and how do we fixate on those? So then we get the concept of driver mutations and passenger mutations. We know we're acquiring mutations all the time. So am I being helpful just looking and telling somebody that mutations are present? Or do I need to be able to tell them that you can act on that mutation if and when you find that? So as a pathologist, as I gather all this information in, how am I going to know which mutations should actually be acted upon and which were just a passenger mutation that were there and had absolutely no impact? So I've summarized some of the things that were put forward in Dr. Vogelstein's paper. In essence, they use different criteria for coming up with what they consider to be driver mutations versus passenger mutations, but utilizing their criteria, and you can argue about whether the criteria was good criteria, bad criteria, they came up with pooled data from the literature of about 140 genes that they would consider driver genes, and that most tumors that were out there really contained somewhere between 2 and 8 of these driver mutations in the areas that they looked at. And that, of course, they can package them into very specific pathways and processes. So just to give you an understanding of sort of what it looks like, if you looked at oncogene-type mutations, which are on the top, those tend to recur at very specific locations over and over and over again, as opposed to the tumor suppressor gene locations, which tend to be deletions that could occur anywhere along that exome. Now, the other thing that I think we need to focus on here, that I need to focus on as a laboratory person that eventually wants to bring these assays out into the clinic, is to reduce the bioinformatics requirement. Because the broader we look and the deeper we sequence and the more we sequence, the more we need to use bioinformatics tools to make sense of what it is that we're finding. And while that's phenomenal for discovery work, we need something that's going to be a little bit more reproducible in the laboratory. And so when I say think big, I want the rest of everybody to be thinking big, but to bring it into a laboratory, I want to start small. I want to get my hand around a set of genes that I can say, okay, here are things that are likely to be driver mutations that are likely either actionable today and likely to be actionable shortly down the road. And so to do that, we're sort of focusing on the TruSight assay, and I'm going to sort of go through why we're doing some of that. I mean, what we want is something that's going to have very high accuracy, that's going to pick the right genes, the genes that we need to look at today and the ones that are likely going to be drivers in the future, something that's optimized on formalin-fixed paraffin-embedded material because that's what we have to do with, and something that's going to provide a wide enough coverage for the genes of interest for us. And so the TruSight panel are 26 targets. They're listed here. They include the things that you would act on today, things like EGFR, things like KIT, things like KRAS, BRAF, MET, et cetera, as well as several others. So one of the things that I found interesting is I took the set that was in TruSight, and in the appendices of Dr. Vogelstein's science article, he had some data on each of the genes. So I went through sort of each of the panel, and he had given them an oncogene or a tumor suppressor gene likelihood score along with the pathway that was acted upon with it. And as you can see, the genes that are represented within this panel are all driver mutation genes, and they fall under categories either of oncogene or tumor suppressor gene, and I've just sort of listed the details out on the slide set here. You can see they actually affect a variety of different pathways overall. There's certainly a lot in the RAS PI3K pathways, but other pathways get represented as well. And the only gene that didn't show up out of the 26, which is interesting because we had done a lot of work around it too, was SARC, which is in the panel but actually doesn't show up as an oncogene in that study. And we've had actually done some independent work around SARC as well, and we're less impressed with the results that we got. So it sort of corroborated what we had seen here. So let me just go over sort of the workflow from our end and what our general approach is going to be for how you bring this into a laboratory. So in essence, the workflow is really extracting the DNA, doing the biochemistry, and then doing the sequencing and analysis. And one of the big deals with this is going to be to ensure that the quality of the DNA, since it's a formalin-fixed paraffin-embedded material, is appropriate for the sample. And we get a lot of questions in the laboratory. Well, I gave you a big sample, so it must be fine. The quantity of DNA doesn't always describe how amplifiable it is and whether it's of sufficient quality to actually expend the money on the library prep to go through the whole process. So having this QC checkpoint is important and it's critical. You can't just rely on sample size itself. The other problem that we've got with formalin-fixed paraffin-embedded sections is obviously the degradation due to DNA. The QC checkpoint helps us with that. But we also have this deamination problem, that the water content as part of the fixation process can change that cytosine into a uracil, and that can create some problems while we do sequencing. And the way you get around that is by having, one, make sure that you're sequencing in both directions, forward and reverse, and that you've got software that's looking for the specific products of that deamination process to control for it and reverse it. And so that's been handled well within the system, so we don't have to really worry about that. The other issue that we wind up worrying about is what's the lowest limit of detection of the assay. So as a medical director of a laboratory, that's one of the most important considerations that we've got. At what point do you call a positive, and what does a negative result ever mean? Because a negative result either means it's not there or it means it's below the limit of detection of your assay. Not necessarily, and we've already seen the dilutional effect and all these other issues that we've got, regionality. So this is an important question, and that has been approached with the variety of different cell lines being diluted out and being able to demonstrate down to certainly between the 1% to 5% level that these abnormalities can be detected. So the way that we're going to bring about this process is a little bit different, because it's very difficult to bring into the clinical laboratory and execute for a variety of reasons, everything that I've gone through, but most importantly is reimbursement. So as reimbursement is up in the air, we're trying to figure out how do we get our hands around this to understand what's the best way to bring these assays forward clinically. Well, as part of our Clarient system, we had acquired a sequencing facility in Houston known as Seqrite. Many of you are probably familiar with it. And Seqrite does full complement of sequencing procedures. And so we've decided to bring this in first into our Seqrite facility and execute it there, along with all the other standards that we've got. So within that facility, we're doing a variety of different NextGen platforms, including HiSeq, MiSeq, but including Life and Roche platforms as well as classic Sanger sequencing, quantitative PCR, microarrays, et cetera. And there we've got, but the idea is that once it's launched within that facility as a biopharm type product, to be able to extend that into the clinical lab once reimbursement catches up to it. And so we've added to the portfolio out to biopharm and other clients to say, if you want to execute this profile can be executed and results will be able to be given, along with the full variety of other services that are present. So really what we're hoping that this is going to allow us to do in the future is, as we get these panels of genes that are going to need to be executed, it's going to allow us to execute it on a single platform from formalin-fixed paraffin-embedded tissue, that the depth of coverage is going to allow us to get the sensitivity that we need. And we haven't really talked about depth of coverage, but in this assay, all genes are read at least a depth of 1,000. I think the average depth is around 5,000. The highest read is 7,000 depth of coverage. And I think that that's probably where we're going to need to be for the sensitivity of some of these things. It will give us the broader coverage, and hopefully we'll take the discovery things that are developed out by full sequencing and allow them to incorporate into a smaller actionable panel overall. So the title of my talk at the beginning was Think Big. I think that's what the world needs to do, but start small, meaning execute in a panel so that our clinicians, when they get a result, will understand what the performance characteristic of that result is and understand how they can act on it. Also, by standardizing these panels, we're going to learn something about which block to select and how to select to actually put tissue into these panels to get meaningful results. So with that, I will end there and be more than happy to take any questions.
Are there any questions for Dr. Bloom?
I wonder if you could comment more on your discussions with payers around reimbursement. I mean, are they seeing the value of these multi-gene panels, and it's just a matter of time, or are they pushing back on the clinical relevance and other issues?
So the pushbacks, I'll comment a couple things on that. So they haven't got to the payment issue quite yet. They're in the phase of understanding what is NextGen and how could it be applied. So Palmetto held a conference 2 weeks ago where they invited a series of other payers. CMS was represented. Palmetto, as the MAC, was sort of representing them. FDA had a presence there. They invited other payers there as well. But that was more to lay out the landscape, sort of what are the issues. My understanding is that they're going to follow that up with an actual reimbursement conference in about 6 months. But here's the problem. So they're trying to understand what should be the payment level around each of these individual genes, things like BRAF, KRAS, EGFR. So the initial reimbursement that came out for BRAF was $50. For EGFR, it was $116. So, you know, when you're talking about those payment levels of genes, and by the way, they're saying we are only paying for those genes which were on the Tier 1 AMA panels, which for cancer were less than 5. So it means that you start adding up. If you could only bill for those genes, you're looking at an assay, whatever you wind up being paid for, probably under $500. Now, we've lobbied that, and at least Palmetto came out with new reimbursements the other day. I think it was yesterday. It might have been the day before. And while they were increased, they weren't really increased substantively. So the $50 went to like $97 for BRAF. The $116 went to $200-some for EGFR, which is good. They're, you know, almost double where they were, but they're still so miserably small relative to things that it's very difficult to understand how you'd be able to innovate at those levels.
Well, what's your feeling then? Do you see this as really the opening bids on their side of a longer conversation, or do they really want to see a smaller diagnostics industry?
No, I don't think that they really want to see that at all. I think that my impression from them is that they just want to understand it. I think we made a big mistake by pushing something as complex as this onto a clinical fee schedule. And the problem with that is their methodologies by which they go about this process just drove the price low. I think if it was on a physician fee schedule, that workload units would have been involved and things would be priced more appropriately. Mm-hmm. Now, the problems with clinical fee schedules is they tend to stay stagnant over time. So if you got a high price, it would be there for a long time. It also means if you got a low price, it's there for a long time. On the physician fee schedule, things get readjusted as workloads get readjusted. But I think that that would be fair because you look at the amount of physician work that's going to have to go in to select the right material and do the analysis and integration on the back end, and that's significant. Sure. And basically, that's free under the clinical fee schedule.
Yeah, the whole thing needs work.
Yeah.
As you're launching the panel, I was, and this is a fairly limited content panel, I was wondering if you could comment on the sort of expansion of it, or on the concept of more is not necessarily better, and especially for the physicians. And so on the sort of on the uptake of the content and content expansion in the clinical community. Thank you.
Yeah, I think that, you know, it's clear that over time, this will not be the only panel, that this will be extended as appropriate genes come to bear. I think this is a pretty good guess, given the list of driver mutations that are out there, of likely genes to be important. But of course, you know, it's a guess. It might be guessed correctly or it might guess incorrectly. So if there's 2 or 3 genes that pop out there that are critically important, then I think they need to be addressed. The other thing that I think is going to become more and more important is the translocation phenomena and whether FISH is the appropriate methodology for that. So for example, there's some data that's emerging that maybe 20% of the ALK translocations are being missed by FISH just because the fusions are too close together and our eyes just aren't good enough to discern that pattern. And so maybe technologies like NextGen applied appropriately might be a better methodology for actually identifying those errors as well. And now you can talk about slightly different panels. Now you're doing a couple things at the same time, looking for mutations and translocations, and the methodologies will clearly be different. But I see us in a laboratory, if we could run everything on one platform, that would be highly valuable for us.
I actually meant I actually meant the contrast between a panel of known mutations with well-defined content and something that is a lot more exploratory as something that Foundation Medicine is doing, for example.
Yep. So the exploratory stuff, I think, has a couple of aspects to it. One is great to do, will payers pay for it? So as somebody that's running a business, the question is, can you really sustain that? Are you doing discovery in your business in the same model? That's difficult to do. The second part that's of concern to me is to act on the mutation when we've got data that mutations in different organs might behave differently. So it creates a sense that I found something and I need to act on it, or I didn't find something so I don't need to act on it, when that may or may not be true. I think as long as it's in the sense that it's in discovery mode, that there's no problems with that, right? And then everybody knows exactly what they're dealing with. I think when you start as a lab, when you can't draw the line between where you have clinical utility and where you have ideas, that becomes very problematic. And in fact, under CLIA, we're required to do that, because to report a result, you have to be able to report the clinical performance, the analytical performance characteristics of that for the question for the question at hand. So what is my sensitivity and what is my specificity and reproducibility for that question? One of the big things that bothers me in sequencing today is I don't understand the heterogeneity enough to answer that reproducibility question. So if I took a different block, how likely would it have been that I would have found that same abnormality in the other block? I know that somewhat for EGFR, KRAS, and BRAF because we've looked at that. But as we get down to some of these other genes, I think it becomes a little bit less clear. Thanks.